With that, I'm going to uh, transfer the slide deck over to Dr. Kouri. Brian, can you hear me?
Okay, so let me again check and see if I'm unmuted.
You're all
Okay.
set, Brian. We can hear you.
Okay, great. Thanks. All right, so Dr. Fishman, again, thank you for your excellent presentation. That was great. We're going to move on now and talk about balloon occlusion transarterial therapy for hepatic malignancy. The goals of my talk, I'm also going to review briefly the pressure-directed embolization principles that Dr. Fishman touched on. I'll then take a step back and just kind of talk about the larger context of the treatment of hepatic malignancy with transarterial therapies and how balloon occlusion technology can possibly enhance that. And then I'll go over some cases to kind of show kind of where balloon occlusion therapy can really help us. All right, so first of all, just briefly again going over the concepts of pressure-directed embolization. Balloon occlusion is based on the physical property that liquids will always flow from a high pressure to a low pressure environment. So basically, when we're using a balloon occlusion microcatheter and we occlude the supply artery, we're creating pressure-mediated hemodynamic changes downstream that theoretically are going to improve our ability to deliver therapeutic agents. There's two main ways to do that. One's non-selective delivery, which is what Dr. Fishman basically focused on mainly with prostate, and the other is selective delivery, which I wind up using more often in the liver. So just to go over these two techniques briefly, non-selective delivery is what those prostate cases demonstrated, and it basically rests on the presumption that a tumor bed is going to have a lower pressure due to the fact that it's consisted of abnormal vessels. And so when you occlude the supply artery proximally, the tumor bed is going to act as a sump, and the normal hepatic arteries are going to be at a higher pressure. So flow will then reverse into the tumor bed preferentially so that you can deliver more embolic agent and hopefully decrease non-target embolization. And like Dr. Fishman was saying, when you do embolization like this, you have to watch carefully, because as you proceed with your embolization, eventually the pressure in the tumor bed is going to increase and it's going to start to normalize with the normal hepatic arteries, and flow is going to start to reverse back into the liver parenchyma. Selective delivery is an opposite concept, and basically what you're trying to do here is get your catheter as distally as possible and isolate either the tumor or the segment that you're trying to treat. Then once you occlude that vessel with the balloon, you can now theoretically put more therapeutic agent, more embolic agent into that tumor. Thereby, you can go beyond stasis often and really occlude the vessel better than you could with an end-hole catheter. So those are the two main techniques that we can use with pressure-directed balloon occlusion delivery. Now, looking at the treatment of hepatic malignancy, first I like to take a step back and just talk about how we approach these patients. First of all, are we going to be able to treat a patient with curative intent or palliative intent? Curative intent is kind of a misnomer because we're often not able to cure these patients generally, because often these patients will recur later. But basically, when we're treating somebody with curative intent, those patients have a small enough tumor burden in their liver that with whatever treatment we're going to offer them, whether it's resection or ablation or embolization, we plan and expect to be able to get rid of all of it, to at least offer them a chance of cure and render them NED, or no evidence of disease. Even if they do recur later, these patients are typically going to have a better overall survival. A palliative situation is a different situation where there's too much tumor to realistically expect that we can get rid of all of it. So either the patient has bilobar extensive hepatic disease, or they have some extra hepatic disease. So in those situations, we're not likely or able to be able to cure them by eradicating all known tumor. Instead, by controlling their tumor burden, we're able to extend their overall survival and hopefully maintain or even improve their quality of life. Sometimes we're even able to downstage these patients to a curative option such as resection or transplant. And so embolization typically falls into the palliative realm historically. And that's reflected in the BCLC algorithm that I'm sure most of us are familiar with that do liver oncology. And so as this table shows, HCC is basically staged according to this algorithm based upon the extent of disease as well as liver function and performance status. And to the left of the table, these patients have the lowest volume disease, the best performance status and the best liver function. As the volume of disease increases to the right and the liver function goes down, as does the performance status, the stage gets worse. And so why that's important is if you draw a line down the middle here, to the left of that line, you've got low stage disease, and you're often able to offer these patients curative treatments, whether that be ablation, resection, or transplant. Traditionally, transarterial therapies fall into the palliative area here to the right of that line. So we're classically talking about BCLC B stage patients that we're going to treat with chemoembolization or radioembolization, but we're also often treating BCLC C patients. Now, in my practice, what's really changed over the past couple of years as I've really gone to using balloon occlusion embolization is that I've been able to find more instances where I'm able to offer curative treatment or curative intent treatments with transarterial therapies. And so that's given me more opportunities to treat these patients with curative intent. Now, the classic example of utilizing transarterial therapies with curative intent is radiation segmentectomy. And this has been around, close to a decade now, and it's classically been defined as transarterial delivery of an ablative dose of radiation selectively into one or two segments of liver. And this technique has basically been developed using end-hole catheters and glass microspheres. However, with balloon occlusion microcatheters, we're now able to use this technique with resin microspheres also, or even extended shelf life glass microspheres, which may be more embolic and therefore may not allow us to do radiation segmentectomy with an end-hole catheter. And so radiation segmentectomy is basically reasonable for patients that have small volume disease, but they're not surgical candidates, and their tumors are either too large for thermal ablation, or they're in a bad location for ablation, or the patient just isn't a good candidate for general anesthesia if you use anesthesia with ablation. And so now let's go over some cases here to kind of illustrate how balloon occlusion catheters can really help expand when you can do radiation segmentectomy. So this is a classic patient that we'll see for radiation segmentectomy. This is a 60-year-old male that has about a 6-centimeter HCC located in the right lobe of the liver. So this tumor is too big for transplant. It's beyond Milan criteria. This patient wasn't a good surgical candidate, and it's too big for ablation in general. And so when this patient was referred to IR for liver-directed therapy, we took a look at it and decided that we could probably treat this with curative intent utilizing radiation segmentectomy. In my institution, however, we only use resin microspheres. We don't have glass. And so to do a radiation segmentectomy with resin, you have to really be able to pack in a fair amount of particles to get enough radiation into the tumor area. Now, with flex dosing that's recently become available, it's not as much of a problem. But historically, this has been an issue using resin for radiation segmentectomy. So with this case, this is a typical case that we're going to do. We're going to start off with just a basic angiogram just to outline the anatomy of the liver, show where the tumor is. And then at this point, we're almost always going to go to a cone beam CT here. And so here, I'd like to put in a plug. As Dr. Fishman was saying, I was going to talk about cone beam. And I basically use cone beam CT for every single liver case that I do. And I do it like this. When I'm in a proximal vessel, usually the proper hepatic artery or the common, I'm going to do a cone beam CT, and that's going to show me where all the vessels are. And then I'm going to use embolization guidance software that's going to help me find exactly which vessels are feeding the tumor. So in this instance, we're able to identify that there's three main vessels here feeding this large tumor. The other thing that we're able to do is then rotate this image digitally, and it really lays out these vessels better, so it makes it much easier to cannulate these vessels. It saves time, and it shows exactly how to get into them. And so here, this was a Steve LAO projection. And what it showed me is that there's these three main tumor feeding vessels. And so basically I had a choice here as far as how to treat this patient to get enough radiation into the tumor to kill it. Now, with an end-hole catheter or with any catheter, you could treat proximally here. The problem is you're probably going to get a lot of radiation non-target into all parts of this liver that you really don't want to. And so to be able to put enough radiation, especially using resin, into this tumor, I decided that I was going to split my activity into 3 vials and then select each of these separately with a balloon occlusion catheter and embolize separately using the selective delivery technique. And so that's what we did. So this is an example of the angiograms selecting the first vessel. I typically use a 4 French Cobra catheter, get out as distally as possible. Then I put my balloon occlusion catheter out here. This is an angiogram with the balloon down, and it shows significant amount of flow to the tumor, but also some non-target flow here to liver parenchyma elsewhere. This is with the balloon up using the same hand injection as Dr. Fisher was showing. This has now reverse flow into this tumor bed. And so I'm able to deliver a significant amount of radiation now into this tumor while sparing normal liver. So we did radioembolization of this vessel. I did the other two vessels, and this is what we get afterwards. At my institution, we've also gone exclusively to doing voxel-based dosimetry, both after the planning MAA angiogram as well as after the radioembolization, to really get a better sense of exactly what radiation, what dose we're giving these patients. And so this is what we see after a case like this. This is a SPECT CT done immediately after the case. It shows very nice deposition of activities, mainly into the tumor with very little non-target deposition. And these are our isodose curves showing that around this tumor, our isodose curve is about 500 gray. And this is our dose volume histogram. And this is what you want to see when you're doing a segmentectomy, is the tumor gets a ton of radiation and normal liver doesn't. So here, using this dosimetry, this estimates that we got about 99% of this tumor got over 100 gray of radiation, which for resin is kind of the dose that we're trying to target to treat with radiation segmentectomy intent. All right, so here's this case. This is the MRI prior to the case. This is 6 months later. The TT, you can see this tumor is basically just melted away. This is the post-contrast imaging. Here's the tumor here. 6 months later, the tumor is markedly smaller. There's no enhancement. There has been some atrophy of the liver, but not that much. And so this is basically going to be a complete response with very little collateral damage to normal liver using resin. Here's another case that we did recently, also demonstrating these principles. This was a patient that was a 70-year-old that had an HCC. He had a resection and has now recurred along that resection margin. He was deemed to not be a good surgical candidate at this point. It's too big to do ablation. So again, we decided to treat this with curative intent using radiation segmentectomy with resin microspheres. And so this is our angiogram to start off with. Here's the tumor here. We did our cone beam CT. We used our embolization guidance software to figure out which vessels were going to it, and basically decided there was one main tumor feeding vessel. So this is an angiogram showing that. I put my catheter out into this vessel, and let me see if I get this to run. I put my catheter out into this vessel, put the balloon up, and this is that yo-yo that Dr. Fishin was talking about here. So there is some non-selective aspect to this, where this is a normal liver parenchymal vessel, which is now reversing flow into the tumor. But as you can see, the majority of this is going right into the tumor here. And so even though there's a little bit of this non-selective benefit here, I basically treated this with a selective delivery technique where I delivered dose to stasis, really. And so this was, so I was able to get the entire expected activity of resin into this tumor. And this is a single shot image at the end of the case, just showing nice diffuse uniform staining of this tumor. And so this is what it looks like afterwards. This is a non-contrast cone beam at the end of the case, just showing very nice uptake into this tumor with very little elsewhere. This is a fused image of the SPECT that we did after the case, fused onto that cone beam CT, and it shows we have just really nice deposition of activity just into that tumor. And again, looking at our dosimetry, we get this very nice dose volume histogram curve where the tumor gets a ton of dose and the normal liver is spared. And so again, looking at our dose tables here, we got about 97% above 100 gray to the tumor with a mean dose of 600 gray. So this is the same kind of numbers that you're going to see with glass microspheres, but you're doing it now with resin, mainly because you're able to pack this in using the selective delivery technique. Once you're able to do that in the kind of the more simple areas of the liver, out in the the main right lobe or the main left lobe, we started doing this with caudate tumors. And caudate tumors are going to be much more challenging. It's a much smaller area, much smaller vessel. But it's a great option because these are not good areas for surgery and they're not good areas for ablation. And so this is a good case of radiation caudate segmentectomy using resin and a balloon occlusion microcatheter. So this patient was referred with HCC. You can see this large HCC right in the caudate lobe. He's got obvious portal hypertension here. He wasn't a good surgical candidate. It's too big for ablation. And so here's the angiogram from that. You can see a very nice tumor feeding vessel here. We were able to get the microcatheter out into it, blew the balloon up, and you get very nice flow into the tumor with very little flow elsewhere. And so this was the single shot at, after we had done the radial embolization. Again, very nice, uniform, dense staining. This is the SPECT CT afterwards, showing very nice, uniform activity. And this is our voxel-based dosimetry afterwards, again, showing the type of dosimetry that you want to see. This DVH curve is very separated from normal liver. This is this patient before, and this was 4 months later. Unfortunately, this patient had a pacemaker, so I wasn't able to get an MRI. I typically try and image all my patients with MRI, both before and after radial embolization, because I feel it's the best way to really tell what's going on. But in this case, you can see this patient has had a very nice response. The tumor is much smaller. There's no definite evidence of contrast enhancement. This is a similar case that we do have an MR for. This is a different patient, but same concept. Had this HCC in the caudate lobe. We're able to selectively catheterize it with the balloon occlusion catheter. This was 3 months later. The MRI shows a complete response. There's absolutely no enhancement within this tumor, and it's shrunk down. This is now 1 year later. It's continuing to shrink. There's no recurrence at this site. So this is a really nice application for balloon occlusion embolization. Even stepping it up a notch further than that is going to try and do caudate segmentectomies with a hypovascular mass. And so one of the benefits of HCC is typically that's going to be hypervascular. It's going to be easier to pack more particles into it. Now, this was a patient that came in with metastatic colorectal cancer, status post multiple lines of chemotherapy, including Avastin, and he had this single caudate lesion. And so he wasn't a surgical candidate, but we could still treat this patient with curative intent by feeling that we could get rid of this tumor with radiation segmentectomy. So that's what we did. Again, we get our 4-French catheter out. We got our balloon occlusion catheter out. We put the balloon up, and you can see on the cone beam that there's very nice staining of this tumor with no collateral deposition of contrast outside of the caudate. So we felt that we were safe to proceed here. This is this patient's PET scan before the procedure. This was a couple months later. Showed very good response. And again, this is the dose volume histogram that we got out of it. So again, basically what all these cases have shown me is that I'm able to put this balloon catheter pretty much anywhere in the liver, and I'm able to treat with curative intent more often than not, because I'm able to occlude these vessels and get a high dose of resin microspheres into them. Moving on, we can also use these same concepts with chemoembolization. And so here's some cases that I did a couple years ago. This first patient had a small lesion, about 2 centimeter lesion up near the dome of the liver. Back then, I did these cases differently. I typically like to do conventional chemoembolization prior to an ablation like this, not because of the size of the tumor, but because of the location. I want to really stain this tumor with lipiodol so I can have a nice target to place my ablation probe. So in the past, I would do this where I would do a conventional chemoembolization one day, keep the patient overnight, and bring them down the next day and do microwave ablation using a conventional CT. I've now switched. I do all of this same day with cone beam CT guidance, but in the past, this is how I did it. And so with this case, we had this patient. He had about a 2 centimeter HCC up near the dome of the diaphragm. So we did a conventional chemoembolization first. And so when I do these, I try and get as selective as possible. It's typically described in the literature as ultra selective, where we're trying to get right out to the tumor. So again, here's our first angiogram, just outlining the vessels. We did a cone beam to kind of give us a pathway to this vessel. We get our microcatheter out there, and here's our balloon occlusion catheter out as distally as possible. And you can see here's the tumor here. So when I do chemoembolization this selectively, the technique that I use, the trick to doing it effectively is to really dilute the lipiodol out. The lipiodol that we have typically comes in a 10 cc vial, and what I'll do is I'll drop 1 or 2 cc's max, and I'll mix that with 50 milligrams of doxorubicin, and then I'll infuse it from this location with the balloon up. The reason why you want to dilute the lipiodol out so much is it's such a viscous agent that if you use a lot of lipiodol, you're going to occlude this vessel very quickly, and that's going to be a transient occlusion, and so you're probably not going to get a great embolic effect, and you might also not even stain this very well. So what I like to do is really dilute that Lipiodol down to where I can barely see it on fluoroscopy. I blow the balloon up, and then I infuse all of the Lipiodol doxorubicin mixture, and then I follow that typically when I'm this selected with 40 micron particles to stasis. And so that's what we did with this case. The next day, the patient came down for ablation, and I typically would do a non-contrast CT prior to the ablation to make sure nothing had changed, make sure that it was still going to be a good case prior to putting the patient under general anesthesia. And so we looked at this, and I said, look, this is such a dense uptake in this tumor. This almost certainly is going to completely treat this tumor. It's a challenging case to do with conventional CT. Let's just go ahead and abort the ablation for now. We'll follow him, and if it recurs or if there's anything residual, then we'll treat it later. The patient was perfectly fine with that, so that's what we did. And this is how he's gone since then. This was 7 months later on a non-contrast scan. You can still see persistent, very dense, uniform staining of this. 14 months later on a contrasted MR, there's still no evidence of any viable tumor there. I think he's now 2 years out with still no evidence of viable tumor. So this is a nice way to do chemoembolization with an ultra-selective technique using conventional chemoembolization and balloon occlusion microcatheter. And one last case, similar concept. This was a guy, again, had about a 2 centimeter HCC near the gallbladder. Again, I like to do conventional TACE first in these situations, again, to stain this tumor so I can really tell where the margin of the tumor is relative to the gallbladder or whatever I'm trying not to ablate. So that's what we did. Here's our catheter here. For some reason, I wasn't able to get more distally here, so I just treated this whole segment here. Again, I treated to stasis using that same technique. This was the CT afterwards. Again, I talked to this patient. I said, I feel pretty good about this treatment. Do you want to hold off on the ablation and see how it goes? And he was very willing to do that. And this has been his results. So this was the pre, this is the immediate post-TACE. This was 1 year later, still very dense staining of that tumor. This is 18 months later. This is the pre-MRI. This is now the post-MRI 18 months later. Again, there's no evidence of recurrence there. It looks like a complete response. I think he's out now about 2 years. Okay, so what I've basically tried to illustrate with these cases is that balloon occlusion transarterial therapy really, I think, offers us the potential now to use transarterial techniques as more than merely a palliative treatment option. I'm not saying this should replace resection or replace ablation, but it is something that's in our arsenal now that gives us more options. And I think when you combine all of this new technology that we have, cone beam imaging, post-processing embolization guided software, voxel-based dosimetry, and balloon microcatheter technology, I think we really can reevaluate what transarterial embolization therapies can do. I think there are more opportunities to use this with curative intent. So that's the end for me.
Brian, can you hear me?
Yeah.
All right. So great talk. I think I'll just say one thing. My radiation segmentectomy is a huge part of my practice. I do a lot of that, and I typically use TheraSpheres, but this is a really interesting application because many people feel very uncomfortable using resin for radiation segmentectomy, mainly because you can't get enough dose in without getting tremendous amount of reflux to get that high dose that you're talking about. And I think this is a really good option for people that want to do radiation segmentectomy using resin, like you, who doesn't have TheraSphere available in glass spheres, and be able to do very, very complicated cases that are sort of state of the art, so to speak, using resin in addition to glass. So I thought that was really interesting. There was a question. It looks like, and this is probably, you should probably answer this one. Any issues with clumping or occlusion when using resin with the balloon occlusion? I guess what they're trying to get at is, do you find that you get stagnant flow as you're injecting it where it clumps, or you get proximal occlusion, or you haven't seen that?
Are you talking about clumping in the vasculature or in the catheter?
Well, it doesn't specifically say, but I guess my question would be, do you find that you get it sort of stagnating in the vasculature itself when you're injecting it or while you're injecting it?
In many cases now, particularly using flex doses where you're using higher activity particles and therefore less particles, I'm actually not going to stasis. It's almost never a situation where I can't get the entire dose and even very high doses. I'm not seeing situations where there's proximal clumping in the vasculature. I have had a few cases, and by a few I mean maybe 2 or 3, where there has been clumping in the catheter itself, in which I was able to either kind of push through it to unclog it, but there have been 1 or 2 cases where I haven't been able to unclog the catheter, and I've had to give up on it. It happens rarely, but I don't know, or I don't think that's a feature of it being a balloon occlusion catheter. I think it just comes down to the inner diameter of the catheter itself.
Right, and most of the, I think most operators that do Y90 know that the IFU really recommends 021 and bigger. So first, if you're going to use very small neuro-sized microcatheters, it's generally considered off-label for Y90. One thing that there was another question. Actually, I have a question for you. When you're disposing the balloon occlusion microcatheter during Y90, do you have any special tips or techniques on how you would do that? Are you worried about particles being attached to the balloon in some way?
I'm not. I used to be worried that the balloon port may be somehow hot when I aspirate the balloon down. So I used to leave the aspiration syringe attached to it and just kind of put all of it in the jar. I've stopped worrying about that. I've done so many cases now. I've never seen any leaks, anything else, and so I'm really not worried about there being any issue with that at all.
So there was a question about PAE, about flow reversal, and the question was, what do we know about BPH and interstitial pressure? And I guess I'll answer that one. I don't think we know enough about that. I don't think this has really been studied to a large degree, but this is definitely an area that or something that interests me quite a bit. I don't know that it behaves like tumor leaky vasculature, which is what one of the questions was. I think part of the reason the flow reverses from pudendal collaterals has to do with Laplace's law, right? I mean, it has to do with the size of the vessel and the pressure in the vessel. And so I tend to think that the smaller collaterals, smaller diameter collaterals in relation to a larger size main prostatic artery reverses better, mostly because the pressure tends to be higher in smaller size vessels. So I find that's what reverses mostly in my experience, but obviously there's a lot of factors and there's a lot of different inflow in the pelvis, and so it's very hard to really understand what the pressure is in all of these branches that are in and around the prostate, and that's why I mentioned when I was showing cases where I left the balloon up and left it down and vice versa, and I will in many cases go up and down several times even in one spot as I'm embolizing and as the flow changes. And so I think we're still learning a lot about how the flow works in the pelvis. I think the liver might be slightly more straightforward, as you presented, Brian, in your depiction of the low and the high pressure embolization diagrams. And so I don't know that it's that simple in BPH and the prostate.
Yeah, I mean,
Oh, go ahead. Sorry, I didn't mean to interrupt.
I was going to say my experience in the liver is that trying to use the non-selective delivery technique, it's a lot less predictable. There are some situations where when you're very proximal, it can help you. And like you showed in the prostate, there's some situations where, it just doesn't help. But yeah, so my experience in the liver is that using it as a selective technique is where I get the most benefit from it.
There was another question about this interlumen and the size of the catheter distally, and whether 300 to 500 size microspheres need to be very dilute to prevent clumping. I'll sort of comment on that a little bit. 2.2 French is the distal lumen, so that's really not an issue at 300 to 500 size spheres. But when we embolize prostate, we tend to be very dilute with the particles, mostly because we're not putting in a large volume of particles, and we really want to make sure we get good particle dispersion and not proximal occlusion. And when I mean proximal occlusion, is not necessarily right next to the catheter tip, but even within the gland itself. I want to have very uniform distribution of the particles as best I can, and so that keeping them very dilute and mixed quite frequently, even during the injection, and sometimes doing a half to 1 cc at a time, and then very aggressive flushing, sometimes 4 cc's of flush per 1 cc of particles, even after the dilution. So we're talking about a very dilute mixture when we do embolization. And you also touched upon that in the liver, how you dilute the Lipiodol, and I think that's a really awesome trick when you're doing liver-directed BTACE, as you mentioned, because if you do very concentrated Lipiodol, you're going to get a proximal occlusion, and you're going to be very disappointed with your result.
Yeah.
There was a question about the OD of the balloon catheter, and we'll go through an 0.35-inch catheter. The answer to that is you should use an 0.38 catheter to deliver this. So there are some labs that stock 0.35 mostly and not 0.38. But in my experience, you're much better off, especially if you're going up and down with the balloon several times, to using an 0.38, and you won't have any issues with that. What do you think about that, Brian? Has that been your experience as well?
Completely agree. Yeah, definitely. Yeah.
There was a question about using Sniper for uterine artery embolization. I have not done that, but I know there's people looking and researching this specific concept. There is some people that think that if you get less non-target embolization of the uterine parenchyma, and again, when we embolize fibroids, we embolize proximally typically, we embolize the whole artery, we don't get very selective. So, the question is, well, if you use a balloon proximally, are you going to get more flow into the fibroids themselves and less into the parenchyma? The theory behind that is that you get less pain post-procedure, and so there's an ongoing study looking at that. So I'm not going to comment on that because I don't have experience, but I do know people are looking at that. Will Lipiodol melt the balloon, Brian?
It will not. I used to be very worried about that. I have never seen that happen.
Neither have I. It's not an issue. In addition, I use DMSO and Onyx with the balloon catheter, specifically when I embolize AMLs in the kidney, and I've had excellent results with that. No issues with the balloon getting stuck or popping or anything like that. There was a question for you, Brian. In your case, why not inflate the balloon proximal to all 3 branches, non-selective, and hope for reversal of flow rather than select each of those 3 tumor-feeding arteries individually?
Right. So this gets back to what I was talking about earlier, is that in the liver, I find that the non-selective technique can be less predictable. When you're that far away, it's unlikely that all of those other vessels are going to reverse and you're going to go just into the tumor. Typically, when I'm doing my planning angiogram, I'm going to do an angiogram from that position with the balloon up and the balloon down just to see. And I don't remember the specifics of that case, but I can virtually guarantee you that when I did that with the balloon up, there's probably some reversal, but not enough for me to feel like I could get a high enough dose or a high enough activity from that position without a lot of exposure to normal liver parenchyma. And so for me, I don't mind, taking the extra steps and splitting the resin a couple different ways so that I can be more selective. So my preference usually is to be as selective as possible, like the cases that I showed you, where I'm trying to really cut down exposure to normal liver, and I'm trying to really get a higher activity because I can be much more selective.
And so you'll draw up several different doses off of the initial resin vial. Is that how you're doing it?
Exactly. Yeah. So basically what I'll do is I'll figure out what the total activity should be, and then I'll kind of estimate, do I think that all 3 vessels are providing the same general perfusion, or do I think that one's providing 60% and the other 2 are 20%? And then I'll just split it up based on that, and then I'll have my nuclear pharmacy just drop the relevant doses. Yeah.
Great. Awesome. So we're just about out of time. We're at 9 o'clock. This was an hour-long webinar, so we're gonna close. I want to thank everybody for attending and listening, and let everybody know that the CME credit will be emailed to all the registrants for this, so you'll be able to fill that out online. I want to thank Brian Kouri and Evolve Medical for sponsoring this, as well as Embolics. And so with that, I think we can close. And if there's any other questions, I'm sure we both would be happy to take any emails offline about this topic, which we both feel very strongly about. So thank you, everybody. Thanks, Brian.
Thank you so much.